Okay, so welcome to Family Caregiver University Part 2. Again, if you can write your name in the chat line, that would be great. We are recording this session just to let you know other people are interested in this recording. So we have a fewer turnout than we were expecting. I think a lot of people are maybe glued to the TV watching the election results today, but we still believe that we have some worthwhile information here. So we are going to get started and going. Because it's a smaller group, you know, if you do have questions, you can kind of wave your hand or other things and we'll try to find you as well. But there is going to be a PowerPoint on the screen. So then the speaker view, everybody's little pictures get a little bit smaller. But I'll hand it over to Carly. She's been really great on coordinating these classes. And I think it's great to share information as well. So I'm going to lead it to you, Carly. I'm going to put myself on mute.
Thank you, Sarah. Hi, everyone. I'm Carly Whetstone. I do outreach here with Area Agency on Aging. I will be starting the presentation off, but Kay Shawley here will be kind of leading it today for the most part, actually. So she is one of the panelists. She is a long-term care ombudsman, also here with Area Agency on Aging. And then we have Bob Callery, and he's also a panelist today. He is our regional MAP coordinator. Suddenly that didn't sound right. And MAP is the Michigan Medicaid and Medicare Assistance Program. So he can hopefully answer some questions you might have about that regarding different facilities. So I will share my PowerPoint now. I just wanted you to be able to see the faces of who is speaking. And let me see if I can, okay. All right, so this presentation is about long-term care options. I guess I already sort of introduced our panelists here. Kay and I are both social workers, just as our background there. Briefly, I want to go over in-home supports. This is what our FCU part 1 was about, and that was last week. And Emily just wrote too, these will both be recorded and put on our website together. So if you did want to go back and learn more about these more specifically, I would just suggest you go back and watch those videos. But I did want to kind of recap. So what private duty care is kind of what you think of when you think of in-home care, I think, for most people. It includes housekeeping. It can be private duty nursing care. It can be personal care, helping with like bathing or toileting, things like that. There's a bunch of different agencies that provide this in Kent County and state and nationwide. There are lots of agencies. So there's different things to look for with that. You can just pay for this out of pocket. Usually runs about $20 to $30 an hour. So it can be a little pricey, but is overall tends to be cheaper than facilities. So it is seen as an option for sure. Care management is ran through Area Agency on Aging, and then Reliance Community Care Partners also has this program for Kent County. And what this program is it offers private duty care, but also ongoing management. So you'll be assigned a social worker and a nurse, and they'll arrange all the private duty care and other services you might need. The other perk of being part of that care management program is that a lot of times private duty care is covered under the program. That the whole program of care management comes at a cost share, so it's going to depend on your income. But thanks to the Kent County Senior Millage, most of the time that's pretty well covered financially. The other program, My Choice Medicaid Waiver, is also something that Area Agency offers, as does Reliance Community Care Partners. What that is a Medicaid program, right in the name, for those who are at a nursing home level of care. And what that means is that the individual could qualify to live in a nursing home. So typically that means that they need assistance with things like, getting around the house. Sometimes a lot of times it comes down to health problems that prevent them from, being able to provide their own personal care, bathing, toileting, transferring, things like that. And this program will cover those services then. So it's very similar to our care management program, but it's a little bit more inclusive. Care management tends to be more individuals who are a little bit more independent, where Medicaid waiver, again, is for those who are at a nursing home level of care. There are financial criteria to be met for this as well. I won't get into that because it gets a little complicated once we go down that route, but here at Area Agency, we're happy to answer those questions. I would just encourage you to call if that is something that sounds doable to you or something you'd like more information on. And then PACE is actually not offered through Area Agency, but I wanted to include it because it's kind of the other side of Medicaid waiver. So it's very, very similar in that all of the qualifications are the same as far as financial and your physical criteria of needing that assistance. The biggest difference between My Choice Medicaid waiver and PACE is that with the waiver program, we'll come into the person's house to offer in-home care. With PACE, it's an adult day center, so you would actually be going to the center to receive your care. So they have a lot of things, including a physician right on staff that you can go see. They do PT and OT and physical therapy and occupational therapy. They have activities, they have meals on site. So a lot of, again, what waiver would offer in home is kind of just the alternative to going to the center. And there are pros and cons to both. And it might just depend on kind of the person's preference too, on what they would prefer between the two programs. And then lastly, Choices for Independence is a program unique to Area Agency on Aging. I actually run this program myself. What it is a kind of a one-on-one meeting where we'll talk about your specific situation, your goals, your barriers, kind of where you'd like to be or what is, kind of concerning you. And we can go over different resources that are available in the community that could be really beneficial to you. So with this program, I see a lot of people who could benefit from things like Meals on Wheels or just learning about the Kent County Senior Millage and the different services that are offered through that. Sometimes it's people who are in a little bit more of a crisis mode, quote unquote, and need bigger services kind of like right now. And this program isn't necessarily designed to do like an emergency, let's surround you and find what needs to be done, but we can help with that. So we can step in at any stage of a person's life and situation. So if you want help when things are going well and you really are fine for the time being, but maybe in a year things are going to look different. You just want to be prepared. I'm happy to come out and speak with you for that. Or if you are more in crisis mode, I can still come out and see what programs are available. Just obviously some programs have wait lists, so the sooner the better is typically the case. It's a really cool program that offers kind of a personalized plan for an individual. Oops, have that slide on twice. And then as far as referrals go, I know I spoke on some programs that are unique to Area Agency. So this is our information to make a referral at the very bottom there. Phone number tends to be the best. Again, we like to get your information, kind of hear about your situation and get a better feel for what programs make the most sense for you. Anybody is able to make that referral. So if you are calling for yourself, that's great. If you're calling for your spouse or a neighbor or a friend or whomever, that's fine. Eventually we'll want to touch base with the person who will be receiving services to make sure they're on the same page. They really do want all the services that their sister is signing them up for, whatever it might be. Because we do really focus on making person-centered plans and wanting them to be built for that client, specially crafted. So we want them to be fitting to the person. So that's why we want to touch base with them, of course, before we start any programs, but anyone is more than welcome to start that referral process. And phone tends to be the safest and the best way. We do have a web page. On our website, there's a form you can fill out to get more information. And sometimes people make referrals that way. Our concern with that is putting out personal information in a not necessarily secure way. So that can be a great start. We just ask that you wouldn't put anything too personal in there, maybe your name and phone number, and then we can follow up with you. So that's why it has an asterisk, because it can work. It's just we want to be kind of cautious about it. And that's the same with email. We're more than happy to work with email. All of our emails will be secure, but we can't guarantee that what you're sending us via email is going to be secure. So there's always kind of a hesitancy in that. And then fax, and that tends to be more for other professionals who are making referrals for their clients, say. Sometimes like hospitals will have what we call a face sheet, and that just has all the client's information, name, birth date, you name it. So that can be a really easy way for us to start a referral as well. But again, phone number tends to be the most common. So that is all I have, and I'm going to pass it over to Kay to talk about long-term care housing options.
Can you hear me okay?
Yes, I can hear you.
Okay. I had problems this morning on another call, so I wanted to make sure that there was an issue. Okay, we went over the community type of opportunities for cares in your home and such with Carly. So now we're looking at some of what the long-term care options are. There are many different levels and options for individuals that really are geared towards everybody's independent needs and preferences. So next slide, please. Did you get it? Okay, there we go. So real quickly, I just went over them. We have the independent living, which is normally when you see IL, that's what oftentimes people will shorten that to be. And then the settings that are qualified as what we think as assisted is adult foster care or AFC, or home for the aged, which is an HFA. They have skilled nursing facilities, which we call SNFs, or the nursing home. Oftentimes I didn't put it on there, but it's just NH. And then continuum of care communities. So basically, in a nutshell, those are the types of opportunity for long-term care settings for individuals. Next slide, please. Okay, real briefly, I mean, we all can read, but independent living is basically if an individual just wants to move to a different type of setting where their, I guess their neighbors are more in more their peer group, if you will. And also a lot of times these independent living situations are homes. I mean, they're independent homes. It's just like an apartment out in the community. It's a home in your in a subdivision, but it tends to have at least it's set up to be more I guess beneficial, or have other options available to individuals residing in there that may need care, access to care in the future. But it really maximizes the independence, and really it is a situation where individuals do live totally independent and they make their decisions for themselves, and it's just like a home. It may be homes that are set up for more situations, such as they might have handicap, equipment in there, meaning, handlebars or, gradual steps just to accommodate needs in the future. So next slide. So assisted living, we always use this as assisted living, but I think that what really important is to understand that assisted living in the state of Michigan is really used only as a marketing term. And it's used for to include two types of really settings, long-term care settings, and one would be an adult foster care, or the other would be a home for the aged. Now, I think a lot of people would prefer to use assisted living because the titles of the two not necessarily are thought as being kind of politically correct, if you will, or it's a little bit more restraining. But just so we know that the state of Michigan does not have a license for assisted living. So be aware of that when people are marketing that. They can have assisted livings and it not be licensed. Whether they don't meet the criteria for it to be licensed, or they, haven't sought to get that, or they haven't gotten it yet. So, but they are required to meet many of the other health departments and the employment regulations and things like that. But just so you know, assisted livings in general, there is not a license for the state of Michigan. Okay, next. So let's look at what we normally think of assisted living. And one is the adult foster care. These are licensed and inspected by the state routinely. There is a licensing consultant that will go into the facilities once, usually I think it's every 3 years, and it just depends. They also will go in and respond to complaints if there is any. So there is an option for that oversight, if you will. Normally the AFCs are less than 20 individuals that are residing there. They are required to have 24-hour, a day supervision or care 5 days a week, or for 2 or more consecutive weeks, that they do that for compensation. So I think that why they're trying to define that for everybody is that because there are situations where you have, individuals that will provide for services, usually under the number of 3 or 4, that do provide for the supervision in that, but they wouldn't necessarily need to be licensed. It'd be more of a family home, and that there also is some oversight there too. But basically, these provide room and board and can accommodate the special diets. Oftentimes, they also are set up as for a group of individuals specific. Some of them will have their population or their residents be, have dementia, that they might be developmentally disabled, physical disabilities, and also a mental illness. So when you look at them, some of them can be very much specialized, and some of them can have, a mixture of individuals. And again, you have to do the application process and all that stuff going along with that. And one thing to note, which is sometimes frustrating too, is not always, as in any other, whether it be an AFC or an HFA or any of the skilled nursing situations, there's no way to force them to take anybody. Okay, so this is still their right to make sure that the individuals they take under their care will be a good fit for their community. Generally, they provide a lot, just more supervision and perhaps some guidance, more of like here what it says, bathing, dressing, and taking medications. So there's still a great deal of independence to the extent that they're able to. Some facilities, situations have what we call, secured premise, meaning that, the doors or there's limited access in and limited access out. And that might be to make sure to meet the safety needs of the residents. So next slide. So the next one is home for the aged. And really the biggest difference between the home for the aged and the AFCs is that one is size. Normally it says 50 to 300 residents. That is, normally what we see, but basically home for the aged really starts at anything like 20 to 21 and above. And the biggest difference between the two is that one is the age. When you're able to go for a home for the aged, they've lowered the age level now to 55. Individuals can go to a home for the aged if they are younger than 55. However, they'd have to get a waiver from the state to show that their situation or their home for the aged is going to be able to provide for the care and is necessary for the level of need that an individual is going to be residing there. And then they will waive the age requirement. Most often, at least in our area, HFAs are attached to or on the same campus of a skilled nursing home. So, in Kent County here, we have numerous, settings that they have home for the aged, and they also have independent living on a campus or in a community that normally then it's well, we'll talk about that little bit later, where they offer a continuum of care. So next slide. Basically, I just wanted to put over what the elements of an AFC and an HFA include. Personal cares, supervisions, protections, supervised personal care manager, and room board. There's a description there, so I don't need to go over all of them, but basically what I think is the most important thing for all of any individual that is thinking that this might meet their care needs or situation, that each one of these settings, while there are some regulations that they need to include within the contract, basically you need to make sure that you review their contract that they are providing for you and look at what the care plan, or what we call, sometimes they call it a service plan, that they will provide for the individual and at what cost, how often, all those things. Because what we often find in a lot of these settings is that there is just a basic, what we would say like room and board fee. Then they will add additional things like, okay, we will provide within that fee, you know, one bath a week. But if you would like to have 3 baths a week, well, then it's going to, and if that's your choice, then some, not all, you know, will then that will be an additional fee for you. So one thing that I always really encourage any individual, regardless of the living situation, is really to review the contract, look exactly at what each one of these elements are, what they are going to provide for you. And if you need to have additional care needs met or other options, that you ask for that and you make sure that you understand what your financial responsibility, if any, will be for that added service. So basically, I want to always say that you have to look at when you go to, let's just say for ease, assisted living situations, that it is basically a landlord-tenant lease, okay? I'm going to pay you this and I'm going to get this. Like we do oftentimes when we go to even rent an apartment. Are my utilities included or is that extra? Is cable included or is that extra? So these are the things that I really encourage people to be diligent about, to make sure that they understand what they are getting for what they are paying for. Okay, next slide. Okay, now we're moving on to skilled. So as perhaps needs, this might be from a medical event or medical crisis that is needing an individual to go to a skilled nursing facility. This is most common. When you have skilled, these where you get from the hospital for the rehab. So when you think about skilled nursing facilities in general, when they say skilled, they're saying that they have the availability for services such as physical therapy, speech therapy, occupational therapy. You know, they have access to a social worker to help reach out to community services and agencies such as the area agency, to make sure that once you go home that you have the services that are set up, and that you also are rehab to the status where you are safe and it's appropriate for you to go home or to wherever, you know, else that is thought to be in your best interest. So that's the biggest thing. So when you say skill, oftentimes what that is referred to in the hospital is that we're going to send you to rehab. There are facilities that are in hospitals that are skilled nursing facilities that only do rehab. They do not have long-term care, okay? So that is something to be knowledgeable about. If the plan is for you to complete a rehab stay and then return you know, to your home or to another less restrictive environment, remember that it's okay to be in skilled because that is for limited. As long as you're there for rehab, that's appropriate. But if you need longer time, then you would need to be transitioned into a long-term care setting. So next slide, I think that would help me. Okay, so now the traditional, what we think is a nursing home. I want to tell you that most nursing homes that we are aware of, they do offer skilled services. So let's say that, you know, somebody has broken a hip. So you will transition, or you'll transfer for rehab to a nursing home that has the physical therapy, has the occupational therapy, has the discharge services support needed at that setting. Most of our nursing homes in our area, in our service area, do have skilled nursing within their nursing home. It's kind of confusing, I know, but just so you know, but when you go in, that is a setting where you can go in as skilled, but let's say then something might have happened to an individual that is going to either prolong or prohibit them to return to their home as was the original goal. Then that individual can then transition to long-term care within that same facility. They might have to move their bed to or their home within the nursing home to another area of the facility that is licensed as long-term care. Really, there's very little difference between what you say the requirements from a skilled nursing home to a nursing home, other than the skilled is just saying that it's the rehab component. What we're seeing here too, I think that one of the biggest challenges that we're having now is that in days gone by, we always thought that nursing homes were really for those individuals that are elderly and compromised. That's, what was typically, I guess, the idea. Well, given, given as time goes on, what we're seeing now is we're seeing a lot of young individuals in nursing homes. So they are not just for the elderly or for individuals that have significant needs. We have a lot of individuals now that, whether it be from a car accident, a traumatic brain injury, so on and so forth, that for maybe some time, then we're going to need extended rehab or extended supports. And so they will be in the nursing home. Oftentimes, unfortunately, what I've been doing this a number of years now, and what we have seen and what I have seen is that a lot of the situation, a lot of the individuals that normally would be in the hospital now are really being transitioned out to a skilled or a nursing home setting. And so we are having a lot more different varied types of care needs and individuals that are residing within this particular type of long-term care setting. Okay. And just to note, I guess, real quickly, for the nursing home and the skilled, they are, of course, licensed, but most importantly, they also have what we call unannounced annual surveys. So what they do is they go in and they really go through top to bottom. Their regulation book is about 1,000 pages long. And the common, I guess, comment that I have heard for many years is that the only thing that's more regulated than a nursing home or a skilled nursing home is a nuclear power plant. So whether that's true or not, I don't know. I haven't seen the regulations of the power plant, but I would venture to guess so. There's a great deal of oversight for these two particular types of settings. So next slide, please. Okay, now it comes into continuum of care, and I referenced this a little bit earlier. We have many communities in our service area that do offer continuum of care. what that is in really easy terms is that you can start by being independent. And if or when your care needs progress, that you can progress within that same community to all the different levels of care that are going to meet your specific needs. Oftentimes, you can live in the condos or the freestanding home. Something happens, an individual then will go to the home for the aged area where there's a little bit more supervision, at least maybe help with taking medications, that they'll help you monitor your blood sugar. There's just more supervision and assistance, and a lot more, your meals will be provided for you if you wish. If you don't, you can still, do it in your own apartment. So there's a lot more options, but yet there's a more safety nets there. Then when you go from what we call the assisted living or home for the aged, then you can go on up to, if your care level continues to progress, then it can go to the nursing home environment. Depending upon each person's personal situation with these continuum of cares, oftentimes what there is there is initial buy-in, and usually it's a significant amount of money, but what that commitment is then is that no matter where or what your funds come to, and if your funds or your ability to pay for these different levels of care, because of the buy-in, and that you are now basically, they'll say a CCC, which is we are there. That's a care contract individual. You will never be transferred out, and they will always make sure that you are cared for, regardless if Medicaid needs to be applied for. They'll help you do that, but you will always reside in that community as long as that's what your preference is. It doesn't lock you into that, but there's obviously going to be some financial probably repercussions if you don't follow through with the contract. So we have a number of different facilities, especially in Kent County, some very large ones that do offer the continuum of care, and you can be part of this program. You don't necessarily have to be a community member to go into the nursing home, but most of the time that is the preference for these types of communities, that they take care of those individuals that are within their system. Okay, is there a next slide? Okay, just wanted to give you a little idea of just how many licensed facilities we have in Kent County, and then also how that compares to the region. So as you can see, overall, and that Kent County has the most opportunities or most settings, both from the 2 assisted living type of settings and also from the skilled nursing facilities. So we are very well situated for accommodating our population's care needs, and most importantly, that there is options for them, for individuals that are needing perhaps either just supervision or some more intense medical treatment or care. So if I'm looking at this right, it's pretty much over half of each, over half of each one of them, which I was almost like, what, 70% or something like that of each one of these different segments of housing. Kent County has that compared within the whole 9 region, the whole 9 counties of our Region 8. So is that the last one, I think, Carly? Okay. Did you have a question, Carly?
I was just going to ask if you could talk about what being a long-term care ombudsman is and what your role is.
Okay, yes, I sure can. A long-term care ombudsman is, the program was developed in the late 70s. It's a federally mandated program that is set up so that individuals in long-term care settings are ensured that they have a voice for meeting their care needs, that it's also set up for evaluation that the facilities are meeting the regulations around the residents' rights. So I am an advocate, basically an ombudsman. It's a I believe a Swedish term, but some people have said it's German, so I'll just go it's a Swedish or German word for advocate. So I'm an advocate for long-term care residents. So what I do normally, as far as for the requirement to meet the federal requirements, and on times other than like right now, we will go in unannounced to all of the nursing homes at least 4 times a year. And we will make rounds. I'll talk with different individuals within the community, ask them questions. How are you doing? What do you like? What don't you like? Do you feel safe? How's the food? You know, what is your plan? What are your goals? Are and that way then I try to get a real good idea of how well the facility is listening and responding to the individual's independent need and really I guess goals. So I'm ensuring that each of the facilities are maintaining that their responsibility to be resident centered or person centered, not the whole residents in one. They need to accommodate the resident and individually. So I receive concerns or complaints or whatever you want to say, or issues, a lot of questions, especially right now, given the state of this pandemic and what it's been doing within all of the long-term care settings. I respond to questions. I get them from families, I get them from facilities, I get them from agencies, I get them from residents, staff, so a lot. So, we're kind of still busy today, even though I'm not able to get into each of the facilities at this point due to that. So we have, let's see, there's 20 of us in the state. We have to be certified by the state long-term care ombudsman. And as currently right now, I'm covering the 9 counties for our agency. So it's funded by both the state, the federal government, and then oftentimes millage money. Mm-hmm.
Thank you, Kay. I wanted to touch on one other program that was not in the slide, and that's because it's sort of between in-home care and a facility, because it's not really either. And that is our program called Community Transition Services. You may know it as NIFTY, or the Nursing Facility Transition Program, and we just kind of changed the name because the state wanted it to be the same thing. But what that program is for those who have Medicaid, who are in a nursing home and want to discharge back to the community, their house, their apartment, wherever they were before they went into the nursing home. Well, I guess not necessarily the same spot, but they want to discharge. So that program will focus on helping you. We'll bring in a social worker and a nurse to talk about what those barriers are. Common barriers are that people don't have a house to return to. And Kay, I'm sure you have a million examples of things like this, but yeah, our team will work, oftentimes including the ombudsman, to make that a successful discharge. And that can include setting up programs in their home once they are discharged and back, to make sure that they can still live safely in their homes. If they don't have a house to return to, or if there's complications with that, we do have a housing specialist on staff as well who can help with that overwhelming navigation of different applications and different grants and all sorts of chaos that comes with the housing market. So she can help with that. And then, yeah, we'll just kind of walk you through getting you from point A to point B. And a lot of times our other programs end up kind of being included with that person's care plan too. So kind of just an overlap. And then Bob, I know we didn't have any slides for you, but I wanted to give you a moment to talk about what you do and what the MAP program is. And if you want to touch on any of these, I'll pass it over to you.
Sure, sounds good. So my name is Bob Callery, and I coordinate our MAP program. MAP is Michigan Medicare Medicaid Assistance Program. We are a statewide nonprofit organization that provides counseling on Medicare and Medicaid benefits. The Medicaid benefits specifically tied to Medicare beneficiaries. So right now it's open enrollment. You turn on the TV. Now that political ads are done, it's going to be all these Medicare ads that are going to be all over the place. So you're in Medicaid or Medicare for the next month. But on this topic, the types of questions that I or the volunteers will have asked of us that we get questions for is, what can Medicare or Medicaid provide for long-term care options? So I'm going to focus primarily on the questions that we get. When we look at on the Medicare end, Medicare does not provide long-term care coverage. So Medicare, again, just like any other health insurance, they're looking to get you better and on your way again. So Medicare doesn't provide any long-term care coverage, don't provide any assistance for assisted living. So, you know, not a lot on the Medicare end. However, Medicare Part A does include a skilled rehab benefit, so skilled nursing in a rehab type setting. But there are going to be costs associated with that, similar to any other insurance. Plus, there is a requirement for a inpatient hospital stay in order to trigger the skilled nursing coverage. Typically, it's going to be 3-night stay under Part A coverage, but right now with the pandemic, they've actually waived that rule. So they're looking to transition people out of hospitals more quickly to keep beds open in the hospital. So right now that rule has been waived, but you need that 3-night stay under Part A skilled or Part A inpatient hospitalization coverage. The problem that you can run into is if you're in the hospital and you're admitted into the hospital, there are two status. You can be under inpatient or you'd be under observation. The observation status actually falls under Part B coverage. So if you have an observation hospital stay, you would not qualify to have that skilled nursing stay covered. If you were to be discharged from the hospital and need to go to a skilled facility. There is a form that's provided that the hospital is required to provide the beneficiary. It's called the MOON form, Medicare Outpatient Observation Notice, and it would have these regulations identified on there to give the beneficiary a heads up that says, hey, if you're going to skilled nursing after this, you did not have the qualifying hospital stay for Medicare to cover that. So you could be paying 100% out of pocket for that skilled stay. If Medicare Part A does cover that skilled nursing after that inpatient hospitalization, the first 20 days covered at 100%. Day 21 through 100, so there's an 80-day window there where there would be a daily copay amount. It's roughly $180 right now in 2020. Then after 100 days, Medicare stops providing coverage. You would need to have another qualifying inpatient hospitalization in order to trigger a new benefit period for skilled nursing. So that's with traditional Medicare. In Medicare, we have two primary routes, traditional and the Advantage plans. So the Advantage plans, that's a lot of your commercials right now on TV. So these are essentially replacement Medicare plans, but they have the same benefits as A and B. They're just administered a little bit differently. For many of those plans, they will have the same type of requirements. They'll have the same cost structure, you know, the first 20 days at no cost, day 21 through 100 at $180 per day. But for some of those plans, they actually waive the hospitalization requirement. So you may not need to be admitted to the hospital to have your Advantage plan cover a skilled nursing stay. So we have had people navigate towards those types of plans just because of that. The other thing to keep in mind with the Advantage plans, not only do they have their own pricing structure for services, but they also have provider networks. So these are HMO and PPO policies. So they have provider networks. So if you want to go to a particular skilled facility for rehab stay, you would want to make sure that your Advantage plan is in network at that facility. Otherwise, the plan may not provide any coverage for you. I actually ran into that issue this morning with somebody. They were in one of the dual special needs Advantage plans, and they were trying to get into a particular facility, and the plan they had, this United Healthcare plan, was not in network there. So they were going to either have to change their Advantage plan. Problem with that is it wouldn't start until January 1, or what they're going to end up having to do is find a different facility to go to that's going to be in network. So lots of things to consider with the Medicare coverage. So the other main question that we'll receive from beneficiaries is, once somebody's ready to, they're not able to stay in their home anymore, they need to move to a nursing facility for long-term care. So we know Medicare doesn't provide coverage for that. Then they'll start navigating towards Medicaid coverage. So we do help people with some of those Medicaid applications for skilled facility or for nursing homes. Couple things: you want to make sure that the facility that you want to go into has Medicaid beds and has openings. Most of these facilities only allow a certain number of people in their facility that have Medicaid benefit. So you have to make sure that there's an opening for you. So I haven't had to do a review of facilities in quite a while, but we were running into issues where, somebody from Grand Rapids wanted to stay locally. Well, there were no Medicaid beds and facilities around here. They're all occupied at that time. So they were having to look at, up in Mecosta County, or Montcalm County, over in Ionia, or out towards Holland area. So another thing to keep in mind is, if you want to utilize a Medicaid nursing home benefit, you have the facility accepts that, and they have the bed available. So again, we'll help people with some of those applications for skilled nursing, for nursing home. There are two Medicaid applications here in the state of Michigan. There's one application that covers over 30 different Medicaid programs here in Michigan. And then there's one application that covers one program, and that's the nursing home Medicaid application. So DHS 4574. So there's this one application for this one program. So we help people fill that out. It's broken up into two parts. The first part is the drawing a blank right now. Next page. Asset declaration. The asset declaration is for married couples, and I'm going to talk about that here in a sec, because there's some unique rules for married couples and their assets. So you have that portion. So if you're married, you'd have to fill that out. If it's a single person, you don't have to fill that out. But then the second half of the application is a pretty straightforward Medicaid application. They're looking to identify income and asset sources. So for a single person looking to go into a nursing facility with nursing home Medicaid, they're going to have assets below $2,000. So that's the asset limit. Question I get a lot of times: well, what's considered an asset? I have, $1,000 in the bank, and I got a home and a car and everything that's in the house. Is that all going to count towards asset? And the answer for that is no. There are some items that would not count towards your assets. So the home, one automobile, all your personal items within the home. That bank account, that would be counted. If you have a life insurance policy, the cash surrender value for that policy. So there are all types of different assets that we help people review to find out if it's countable or not. For a single person, for nursing home, for their income simply has to be below what the full cost is for the facility per month. Because what's going to happen is, for that single person, they are going to be assigned a a dollar amount that they are going to have to owe to the facility. It's going to be their patient pay amount. Essentially, that patient pay amount is going to be all their income minus the $65 personal service amount that you get to keep, and then any amounts for premiums for insurance plans, health insurance plans. So essentially all their income's going to the facility as a patient pay amount. And what Medicaid does is they step in and fill that gap from that dollar amount up to the cost of the nursing home for the month. So that's Medicaid's role for single person. In addition to that, they also have full Medicaid health benefits. For a married couple, they have some unique rules for assets. There are, I don't want to go into too much detail because it took me months to finally wrap my head around this to explain to people. But there are protected asset amounts where if you fall between a certain range and it's around $25,000 to $128,000, that's a protected income amount. If you're below the $25,000, the couple gets to keep all of their assets. If it falls somewhere between that range, what they'll do is the state of Michigan will divide their assets in half. The spouse in the facility would be able to keep $2,000. The community spouse would be able to keep a half, and then that other half would have to be essentially spent down. But there's a range for protection on those assets. So people don't have to spend all their assets down in order to get into a nursing facility with Medicaid. Income. So we get that question with income for a married couple. The person living in the community will be able to maintain all of their income. For the spouse going into the facility, there is a special formula that the state of Michigan runs their income through to see if maybe a portion of that income can go back to the spouse in the community. So if they have different home expenses, that money can be able to go back to that person to help pay for those items. When you fill out the application and submit it, state of Michigan automatically counts all that. If there is any income for that the spouse in the nursing facility that does not go to the community spouse, they could also have a patient pay amount. So some of that money then would have to go to the skilled facility. So the facility would send them a bill. They would receive their income through normal avenues, so Social Security into their bank account, and they just have to cut them a check for the patient pay amount. And again, Medicaid is going to pay the difference between the top of that patient pay amount and the full cost for the facility for that month. So our volunteers, I only have a couple volunteers that do the nursing home Medicaid applications. I do quite a few of them. Once you start getting into certain assets like trusts and annuities, complicated situations like that, or if there's a lot of asset there, usually we don't feel overly comfortable handling those situations to where we'll actually refer you to contact an elder law attorney to navigate those applications, because there are some things that can be done to protect some assets that we don't do that. We just report all the information. So, but we get all types of questions with Medicaid and nursing facilities. So we can go find those answers in the Medicaid policy manuals and or other community resources that we have available. So that is all I wanted to talk about today. So thanks, Carly.
Yeah, thank you, Bob, for that great information. Do we have any questions from anybody? I didn't see any in the chat, but I wanted to invite you. You can just take yourself off mute if that's easiest, if you do have a question. Looking quiet. Well, one thing I wanted to point out on that PowerPoint, I had the wrong phone number on the last slide of the PowerPoint that was emailed out. So what I was showing you guys is the correct number, but if you do have that as your handout, if you printed that out to reference, I'm sorry, that number is incorrect on the very last slide. So I just wanted to let you know, again, what was presented up on the slideshow today was correct, but the handout that was emailed earlier was incorrect. If we don't have any questions, then it looks like we will wrap up early. Sarah, I guess I'll pass it over to you.
Yeah, let me pull up, or if Bridget, you have it right here, we'll pull up the evaluation. I'm gonna put that in the chat box. Okay. If you can take some time and maybe grab that link. Oh, Bridget, we did it at the same time. If you can take some time and grab that link and hopefully fill that out, give us the information. Like we said, we are always available to answer those questions. We thank you, Carly and Bob and Kay, for your time. But please fill out the evaluation. Hope you all have a great day. Make your choice. Do you want to go watch the TV some more or not? Whatever is best for your mental health. So thank you all again. Hope you have a great day and we will talk to you later.
Thank you all. Have a great day.